welcome to yet another edition of the Expressions with the New Express. I have with me one of India's premier cardiologists. He's broken every heart-related record in the book, I think, from angiograms to angioplasties. I don't even know what they are, but I know that they're very important. He's also chairman of Fortis Escort Heart Institute. And really one of the key people who's helped us understand and come to grips with this COVID crisis. And he's been at the forefront of explaining things to people, of spreading awareness. So welcome, Dr. Smith. I know you're very busy, but it's a real pleasure and privilege for having us. And of course, your old friend, Mr. Chawla, whose heart is in very good condition, I think, partly because of you. I'd really like to start off asking you by saying 6 months on, how much do we know of this disease? How much do we know of the precautions we have to take? And really, how do we now learn to live with it? Because that seems to be the new normal.
Thank you very much, Kaveri, and good evening, Mr. Chawla. It's just indeed a pleasure to be with you all and having this conversation. Mr.
You're seeing me on the, sorry.
I was saying Mr. Chawla's heart is young. So he's a young person, and there's no reason for him to be in any, but you're always very raring to go. So you're so right about COVID. I mean, it's an unprecedented form of an infection by a very new virus. And even now, many a times we think that we come up with surprise new learnings around this virus. When you really think of the fact that this is absolutely a submicroscopic and arguably even a non-living particle. And when you think of a non-living particle creating so much of havoc that it stopped every country in its tracks, it stops everybody's life in its tracks, it actually brought the whole world to a standstill in an unprecedented manner, which we never ever imagined even in our dreams. It's weird sometimes to think that it just shows how much we don't understand about many aspects of the creation of this world, the creation of these objects, how they can affect us. And science is still researching on this particle every day. Perhaps the largest number of papers which ever came out on anything was COVID in a short while. So while we talk about the virus multiplying, we've also talked about literature multiplying, we've talked about knowledge multiplying. And while we sit here at 6 months from here on, there are certain facts that we've got it right, we understand better. But still there's a whole load that we don't understand. For example, what we do understand is the symptoms, and certainly we as humans, what precautions can we take to avoid getting it? But what we don't understand is any aspect of its treatment. In fact, we're still away from its prevention. We don't understand how long this virus is going to be with us. And we still don't understand whether we'll ever be able to normalize our lives, even though we should be positive that we at one stage would normalize our lives.
So what is it that we know, doctor, that we have to now keep in mind going forward?
So let's very, very clearly we know that it's almost like a common flu,
right,
and clearly spreads by droplet infection, which means that it has to be a cough or a sneeze where droplets actually get to another person and go and enter through the face, which is nose, mouth, or eyes. Now, there's been concerns regarding whether it actually floats in the air, whether it's air spray. Well, those are unproven, I would say. And we would actually have to start understanding that droplets is what we're preventing ourselves from. And therefore, the issue around wearing masks is related to the fact that I hold a responsibility, not just of protecting myself and preventing the droplets from coming to my face, or putting my hands, which could get infected from any of the surfaces, to my face, but I also have an equal responsibility towards everybody else of not passing those particles, which I may have, to someone else. So this whole issue about masking, and I would actually say appropriate masking, and that's another thing which we've learned, is that we cover our nose, we cover our mouth, and not just hang a mask in our neck as an ornament, which is so important. We not just owe it to ourselves, we owe it to everybody else. It is a civic duty. In fact, I would say that it's a criminal offense not to mask yourself appropriately. The only reason you, Mr. Chawla, myself are not masked at this moment is because we're alone in our room. But the moment we step out, we have to wear a mask. The second thing about what we've understood is the physical distancing. And this, by the way, I want to explain this also, that this arbitrary of 2 meters or 6 feet, etc., is all arbitrary. In a controlled lab-based atmosphere, it's been seen that your cough droplets go as much as that. But if you had a wind behind you and you were standing there, the droplets may actually go for 10 feet. If it's a closed atmosphere with air conditioning in a closed room, it could actually be even longer. So it's not as if 6 feet saves you and 5.5 doesn't save you and things like that. Distancing is here, that you be as far away and not close to each other. And the third aspect is it has trained us now. The good part of it is that we now do namaste. All those hugging, etc., are gone across the world. Chahe wo salam ho, chahe namaste ho, chahe sat sri akal ho. It's all here, and this is all cultural. And of course, we wash our hands, keep ourselves clean, sanitize as much as possible, and those are good things. So there are certain good things which have come out of our learnings. But the other thing that we've also, so we've realized this, and I think that perhaps this part is the most important. And of course, we've realized the symptoms, which is, initially it was just thought that it could just be a common flu or a common cold. Yes, that still exists. Ki fever aa gaya, khansi aa gayi, zukam aa gaya, sardi aa gayi. But interestingly, even loss of taste, loss of smell, both can occur even a couple of days prior to developing the virus. Asymptomatic situation, which we didn't know earlier, is coming more and more to the front. People can actually be asymptomatic and still spread the virus. And of course, mild diarrhea and gastroenteritis-like symptoms are again one of the presentation features. And yes, strokes and heart attacks are also presenting features of this virus. So more has come to be known about the presentation. And I think these two are the firm knowledges that we have at the moment.
Doctor, we talked about the social and cultural changes. What are the medical aspects of this? What are the things in our healthcare system that COVID has exposed for us and has shown us that this is the moment now where we have to fix it? Otherwise, it'll be too late.
So Kaveri, you're so right. For the first time, I saw people talking about healthcare, the infrastructure, what do we have and what do we don't have, what are the value of a doctor or a healthcare worker for that matter. Recently, over the last few years, doctor became a profession which was being bashed often and more easily. And in fact, the confidence on the medical profession had gone down due to isolated instances, of course, but that gets spread around more it seems that it becomes the norm rather than the exceptions. And that's the perception that patients and public started having. So certainly it brought those issues to the forefront. But what it also showed the various gaps in healthcare. Now, let's first understand that nobody expected that we would need such vast amounts of healthcare, infrastructure, equipment, as has been seen in this pandemic. Even the West, which is usually far above in its healthcare spends as well as healthcare infrastructure, could not cope up with the infection, with the COVID-19. So, but it actually drew attention to that. I think that's what the issue is. It did not draw attention to the fact that our healthcare was inadequate, because even the Western healthcare became inadequate. But it drew attention to 2 or 3 things. First was, yes, healthcare is important. Healthcare workers do sacrifice their lives for taking care of the patient. And thirdly, we certainly need to have indigenous manufacturing and indigenous production or the readiness for it, almost like we do in a war, where we should have the readiness and be able to ramp up rapidly if such issues were to arise. And I think those were the very important ones. But, as a country, we've been devoid of policies for such things. Atmanirbhar is extremely good, but Atmanirbhar should have been there much earlier than this and should have been there much earlier than this. For that, one needs to really revamp policies in a huge way so as to make it entrepreneur friendly, for them to be friendly to research and innovations, and then for it to be rewarding for research and innovations, to say that we're actually going to have an all-round emphasis on creating a great infrastructure of healthcare.
Doctor, I will ask you one question here. You're speaking about the infrastructure, healthcare is not sufficient enough in India.
Right.
Even after 6 months, do you think that is enough to handle the situation which is developing every day? Because my personal experience is that even after 6 months, you don't have enough facility to look after each and every patient which comes to your door for some kind of advice.
So there are 2-3 aspects of infrastructure. There's no doubt that nobody could actually understand the path to chalk out. This was a purely untrodden area. And in fact, some of the actions which were taken in the West, we are lucky that we didn't follow them, because actually what we saw happening in the West was a late realization of the infectivity process till the infrastructure got overwhelmed. And this is the most advanced infrastructures that we're talking about, overwhelmed by the visuals of what we saw of deaths happening in huge numbers. In fact, it's of situations where numerous patients were flooded, trying to be ventilated and ventilation being rationed, and cemeteries having lines and queues of people to be buried. That was what the visuals, and this is clear, this is not just visuals, this was my conversation with my cardiology colleagues in the United States, where all hands were on the ground, everything had stopped, everybody was treating COVID, and there were scores of patients in COVID. When we actually see those deaths and the number of deaths we died, we actually felt that we should not follow that route and take the route of early lockdown. And I think what it did for us, it's not so much as the spread of COVID, which as you unlock is going to happen, but it actually firstly taught us a lot more about COVID. It gave us time for the public to start realizing the scourge of COVID. What can it take to actually prevent it? What are the precautions one needs to take? It also helped us to actually think of, at that time, an N95, a PPE was a 1-week waiting list and would cost us 2,500 rupees. And when we got our first 200 PPEs at that time, that's what it took us. Now the PPEs are available for 185 rupees, and you can actually have as many as you want. It helped us to ramp up those sort of production issues, which even the West was suffering from. In fact, the West suffered from a lot of doctors catching COVID because inadequate PPEs and inadequate N95, they were always relying on China to provide them. The second aspect which happened was, of course, that it gave us time to say, how do we actually how do we fight this virus? So there were a few aspects which arose. The treatment options became more, and the treatment guidelines, even by the way, even till now, that there's only 1 or 2 drugs which can cure COVID or which have actually saves lives in COVID. But at least the protocols became more defined. Earlier, what were we saying? We don't know what to do. Let's just use anti-AIDS drug, any antiviral drug. Or let's start using chloroquine. We were repurposing drugs. Every protocol in every center was different. AIMS had another protocol, and yet Boston had another protocol, and Cedars-Sinai would have another protocol. Now, it's all much more defined and refined. So we are now able to actually treat our patients more systematically, knowing when to use which drug, rather than use a drug later. We know it or what time to use it now. And thirdly, of course, that we knew that unlocking would expand the virus, but we were able to at least create more beds, create more ventilated beds, create more ventilators. And also, one of the biggest things which came in, by the way, is 100% of the patients of COVID would be admitted in the beginning because of lack of understanding and would only go out of the hospital when 2 COVID tests 48 hours apart were negative. Now, majority of the patients are actually being treated in isolation at home, understanding that this can be done, that there are indicators when a patient should be admitted, and who are the patients who should be treated in hospital. So, Chawla Sahib, you're right that if we said, let's admit all the patients, then we would actually be devoid of the beds. But even at this time, as we talk today, we know that beds are vacant even in Delhi. Even in our hospital, which has 100 beds for COVID, we have available beds. And that's because moderate and severe patients are being admitted to the hospital. The ones who require most care, which probably constitutes 5% of all COVID patients. And then, of course, there's a huge population which is quarantined and being treated at home.
Doctor, what I meant was that even level 2 and level 3, which are the serious cases, basically,
Right.
level 2 people require oxygen, and level 3 go to the ventilator. But I find from my personal experience that you have to call a big person to get a person admitted into a good hospital like yours or anybody else, even if you're the bed. People are waiting outside. What I meant when so much of time was available,
right,
created infrastructure, you got PPE, but patients still, if they are not, they are willing to pay, but they are patients who can't be admitted because you have a shortage of doctors or what, I don't know.
You're sure, no, that
absolutely. People have to call at the top level to get admitted into hospital.
Yeah, you're now got, you're saying that's absolutely correct. See, just beds and putting in beds is not net the bed strength. And somehow what we keep hearing and what we keep reading is X number of beds, but beds have to come with expertise, beds have to come with doctors, with nurses, with care, with other ancillary equipment and everything else. Yes, I think that we have to really take a stock of that situation, because we are hoping that the worst is over, but it's not going to be over for quite some time. And this is a regular stock check, regular stock taking, repeatedly putting in efforts, infrastructure, and ramping it up as we go along with a projection of a month and 2 months ahead. Otherwise, we will always be falling behind it. And so you're absolutely right. More care should be given. We shouldn't just think it's a bed issue. We should think that it's still an infrastructure issue. Right. And the infrastructure issue has a number of elements which have to be always looked at and accountability taken as we go along every 2 weeks to every month. And the projection have to be for the next 3 months.
Doctor, another thing which I have noticed that there are different protocols for different hospitals and districts. Yes. CMS are made in charge of the hospital protocol. You may be having some chief medical officer in the government of Delhi, which may have prescribed certain protocol for you. Okay, level 2 person has to be in hospital for so many days. After so many days, you have to test them again. So there's different protocols by different people all over the country. I've heard about 20 different protocols already.
Yeah.
Is that right?
You are, see, at the end of the day, every state has been in a different stage of the disease process. And the disease did not percolate it always percolated at different time frames and is ranging at a different time frame. You saw initially that Kerala had it first, but it appeared that Kerala had it under control. And in fact, we used to then say, Delhi and Mumbai is going really bad. We should follow the Kerala model.
Correct.
Then we actually also started hearing, but we should follow the Bangalore model. They seem to have had very few cases, and you recall that conversations where the Bangalore model was being propagated. And then we see again that actually Delhi is sort of at the moment flattening after a huge,
There's talk about Delhi model also.
And that's right. Then there's talk about Delhi model, and then you go backwards, and the Kerala model again. Again there's a surge of cases, and they're rethinking the strategies. You see, India is a vast country. India is got a dense population. India's strategic models cannot be, it has to be individualized to that region and to that area. And policies would have to be always reviewed and developed. If we actually said, oh, 3 months ago we created this policy, that will actually fail within 2 or 4 weeks. You'll suddenly realize that policy was totally ridiculous, because there is no path. There is no path which has been created. It's intelligence at that particular point which says, this is what I know. Let us create a chart for the next 1 month and then review this, whether this has worked itself out or not. Otherwise, we cannot believe that we would actually, after all, many brains put together, have still not been able to chart out any path for any country, as you can see. If you can see the models of what's happening in Madrid, Madrid is going back now towards relocking itself. UK is going backwards to relocking itself, having got its initial policy totally wrong, then its mid-policy partially correct, and now again feeling that it's got its policies wrong and going backwards. You saw Sweden. Sweden had the biggest mortalities happening because Sweden thought its policies of letting this virus go into its population, because it had a great infrastructure of the healthcare, would actually develop herd immunity, and therefore, and yet they would be able to save patients. And then they suddenly realized that everything was wrong. So I think that we cannot be too intelligent about this virus. We cannot be too intelligent. We cannot believe that all of us can understand all the requirements which will happen. But we still, I would have to emphasize one fact, that nobody has an excuse that if things are going wrong, not to review the situation and not to actually get experts involved to chart out a different path rapidly to get hold of the situation. That should not happen.
Doctor, one of the problems with India's healthcare has been we have this double burden of communicable diseases as well as non-communicable.
Oh, yes.
And you know that better than most. Somehow, when we focus on one, we lose focus of the other. And even during this pandemic, there have been reports that surgeries and preventive interventions in other areas has been stalled. Is that so? Have you seen this in your case as well, that surgeries in other areas have actually suffered? People have actually not got adequate care?
So we've always had, at least, you see, we are a tertiary center. So we actually have 100 COVID beds, but we also have other beds available. It's not stalled for us. Patients themselves have felt scared to come to the hospital.
Right.
And that's been the experience across the country. So after the lockdown, of course, the concern was that the emphasis was of physical distancing, the emphasis was on taking care. And also remember, the emphasis was even from our side, was that don't come to the hospital unless absolutely necessary, because we felt that we should not overburden the infrastructure of the hospital, because we did not know what to expect. Because if you recall the visuals of the West, the hospitals were overwhelmed, inundated with patients of COVID, with not a single bed for anyone else. It was all COVID, because it was all hands on the ground. Even the cardiologists were treating the COVID, the anesthesiologists were treating COVID, even the gynecologists were treating COVID. Because at that stage, we ourselves told our patients, please stay away from the hospital, because we felt that we may need actually the infrastructure for COVID patients. However, that did not happen, and we still had beds. So as we unlocked, but the patients still felt very scared, and they still do, by the way, even as of today, as I sit in the OPD and I tell patients that they need the procedures, they still say that can't we postpone it for a couple of months when this COVID goes away.
Right.
So yes, in fact, at that time, it was also seen that the number of heart attack patients coming to the hospital, which is an absolute emergency where they have to come to the hospital, irrespective of whether they like it or not, actually also went down to a 1/4. And whether people died at home, the Westerns do have figure that they also had a decrease in number of heart attacks coming to the hospital, but there was an increase in number of deaths from heart attack while at home. So patients did suffer from not coming to the hospital or from postponing their treatments. Our concern now is that if this continues, and certainly no system should be put down which does not allow you to take care of non-COVID patients. Non-COVID patients need treatment. Non-COVID patients should have treatment. They, in fact, have equal right to have treatment. Everybody needs the right to have treatment for their illnesses. So there should be no actions of that sort which differentiates between COVID and non-COVID patient, apart from the bed creation for COVID patients, which cannot differentiate that a non-COVID patient cannot have treatment.
Doctor, I saw the figure somewhere in Delhi, also in other states.
Yeah.
Number of deaths due to heart attacks and other diseases is much more than the COVID deaths. Is it correct?
Absolutely. I mean, that has been there all the time. I can tell you the figures that nationally, 7,000 patients die from a heart attack. But at the moment, as you know, nationally, 1,000 patients die from COVID. So,
sometimes more.
That's right.
Yeah.
And that is known.
We don't pay that kind of attention to heart attack.
No, I've said this openly in various forums of interviews, that every COVID death hurts. But let us not forget the fact that more people die from other illnesses, far more people die from other illnesses, and therefore our concentration cannot be devoid of what we need to do for non-COVID patients, their cancer patients, their heart patients, their lung patients, their patients in every disorder, lives which can be saved every day. With the same rigor as we save COVID, lives can be saved every day. I'm sure heart attack patients, death due to heart attacks must have increased at home. Unfortunately, we don't have those Western systems where you dial for an ambulance and an ambulance picks you up. But Chawla, in the West, it's clearly documented where they dial a 911 and the only way they get to the hospital is by ringing an ambulance, which comes in 5 minutes' time. The time period showed, both in Italy and in the United States, that deaths from heart disease, heart ailments actually doubled during that time frame, in which heart attack patients decreased coming to the hospital. People suffered. That's what it was. And therefore, the emphasis clearly is, come to the hospital if you need to be saved. If you have a disease process which is getting worse, if you have an illness which requires urgent attention, you must get to see a doctor. If it needs admission, you must be admitted. If it needs treatment, you must be treated. Please do not ignore your symptoms. What we only say is, if you've got a routine checkup due, that can easily now be done on teleconsultations. It can be done on phone. It can be easily done. And a routine trip to the hospital can certainly be avoided at this stage.
Doctor, I'm doing a different thing. I don't know the figures about survival rate of a heart disease patient.
Correct.
COVID, it is reaching almost 90% now, but you're getting it. What is the percentage of heart disease people whose survival rate? You must be doing better in India or anywhere.
Right. So you're talking about heart attacks.
Heart diseases, people suffering from heart attacks.
That's right.
How many
Heart
people
attack
survive?
is one of the emergencies, because heart disease can still progress over a long period of time. But a heart attack is an emergency, just like COVID becomes an emergency.
Yeah.
And at the moment, if a heart attack occurred and we were able to actually get to him in time, we would actually save 98% of them. So again, this just shows the fact. And as you can imagine, when I said 7,000 people are dying from heart attacks every day in this country, that's a huge number of people. Now, how many of them did not get to us? How many of them we could not save during this time is a real important issue in our mind.
So don't you think that COVID is more a hype than so much money you have spent so much money in 6 months that may not have spent the entire 25 years of medical care, the kind of you spent now.
No, I don't think
it's very scary.
I know. It is not a hype. The difference is that this infects from one person to the other. The non-communicable diseases are not infecting each other. And that's the whole issue. So the extent of the number of people who can die if we didn't control could run into crores. And that's the real issue. It's an infection versus a non-communicable disease. And it's a vicious infection because it transfers and lives on transferring from one person to the other. So we cannot equate it. We're just saying, thankfully, we got 1,000 deaths. But believe you me, it could have been unthankfully, and this we could be facing 20,000 deaths a day. We've seen that happen. By the way, you know, I must say that we're talking about a lack of deaths in a nation of 1.3 billion. We talk about 1/4. America is twice the more deaths in a nation which is 1/5 our population. And if you talk about England, 10 to 15% death rate was 10 to 15 in England. That's why you saw those visuals where even for the emergency, the number of ambulances waiting to take patients to the emergency had spread to 8-mile long queue. And for the cemetery, number of people being taken to the cemetery was similarly a 2-mile long queue in Italy. So we don't want to see those visuals, because with the density we have, you cannot even equate it to acute a heart attack, which is a non-communicable disease. Yes, heart attacks developed over a period of time. It doesn't take away the fact that we got to fight it. This number of deaths can actually happen in the next 6 months. Whatever deaths we saw over the last 5 years from a heart attack, if we weren't careful, could happen in the next 2 months as far as COVID is concerned.
Another question is baffling everybody. Why this 70-80% of the cases are concentrated in few areas of India? And they are recurring there again and again and again. Is there any biological reason, sociology reason? What reason is there? Why it is happening only concentrating on certain areas?
Like what, Chawla sahab, you know, which sort of areas are you talking about?
I'm talking Maharashtra, Kerala, Tamil Nadu, Andhra, because
no, we're actually seeing a gradual. So those areas which few months ago we said are safe are now getting gradually unsafe. Of course, for other areas we know it's a congestion issue. The number of people per square. So Mumbai, we know that it's actually an enclosed area with the maximum congestion which perhaps exists. But you know, if you see, new and new areas are coming up of increasing COVID. As it goes downstream and as it goes into those areas, as the population migrates, it started from the big cities because it actually came from outside the country. And as it started in the big cities, which were connected by air to outside cities, and we know that's how it happened to Delhi, that's why it happened in Mumbai, we know that's how it happened in Kerala, where the first cases came from. We exactly know where they came from. And then as you track them inwards into the country and into the smaller towns, and as people have moved on. So no, it's not congestion. In fact, you will continue to see those areas which are lesser now will actually get them one day. That is the concern at the moment that we have, that the peak of India has not happened. We're still on the upslope. There is no second peak. We're still talking about the first peak. It is just going inwards and inwards and inwards into those areas where migration of population continues to happen. And when we will see that peak is what we don't understand about this disease process. So this talk about 2 mahine, 3 mahine, 4 mahine is a very arbitrary figure, and nobody can be as intelligent as anybody else because we don't know when India peaks and India plateaus.
It means you are saying still the first peak has not arrived yet.
The first peak is continuing. You're right. The first peak has not arrived because we still
don't know the number. What will be the peak?
Upslope of the country. Yes, we don't know the number because at the end of the day, to tell you frankly, you know, you can actually say we haven't tested enough at some stage. We're testing more now, but internally going inwards, how many testing is being done? We don't know how many of that population which lies into the smaller town and rural areas will ever get tested. We don't know how many cases will actually turn up. One thing we can sure, at least to some extent, is partially are hard numbers, and unfortunately those are sad numbers, is the death. And death, unfortunately, cannot be hidden away anywhere. It comes in front of us. And if we just follow the death figures as a representation of the COVID which exists in the country, then at least those figures are not, you know, are representing at least some form of protection of the Indian people in some way or the other. Because if you actually understand the 1.3 billion all congested into perhaps second most or third most congested country in the world, one would actually think that this would be spreading like a wildfire, like a fire which could not be controlled, with thousands of deaths happening on the street all over. And yet we're not seeing that. So we have some reason or the other to believe that perhaps God's been kind to us in one way or the other.
Maybe the Indian immunity system very high.
Correct, correct.
Because
So,
you to living हाथ धोने की हमारी आदत है, खाने से पहले साफ रखना है, ये सब.
You're so right. When people come from abroad, in 2 days they start getting diarrhea and dysenteries and all sorts of infections. And yet the people who live here can eat from anywhere, eat anything on the road, can pick up a food from any hawker. And you know how much dust and things which exist there, and yet do not get infected. So there are a number of reasons, of course, younger population, innate immunity, BCGs, there are hypotheses all around. But yes, there is, all said and done, there is some protection happening to our population in this country. But the peak is going to be there. We just don't know how bad the peak is going to be.
Doctor, I just wanted to focus your attention on the medical care. You said that, you know, for the first time, health workers and doctors were appreciated and their importance was understood. Going forward, what are the changes we can bring about in the medical education system to make the medical profession attractive as an option in a country where we still need so many more doctors and nurses?
So firstly, of course, the medical, so let's start off with many aspects to this. You know, it's practically a revamp at the whole healthcare or the whole education system. And if we revamp healthcare, we've got to start thinking about how do we revamp education system. One thing is very clear: the doctors are devoted. The doctors are truly have actually given, and I say this for healthcare workers, not just doctors. They've truly shown their mettle. They have sacrificed during this time, all healthcare workers, and taken care of COVID patients without worrying about their own self or their families. And I can actually tell you visuals of what I have seen, where doctors have actually got COVID and yet continued to save lives in the COVID ward where they were admitted, by making sure that a person who was getting breathless gets intubated, even though they themselves were admitted with COVID. I've seen doctors not worrying about even wearing a PPE and rushing to save a life of a COVID patient by intubating him without a PPE. I've had colleagues who've taken patients with cardiac arrest who had COVID without even bothering about PPEs and taking them for an angioplasty and saving lives, only later sitting down and saying, fine, I've saved that life, but I didn't get PPE, I may get COVID, isolating themselves from their family and breathing a sigh of relief only after 10 days when they didn't catch COVID. So all those stories are around us. When I say revamping the healthcare, so certainly the respect for doctors, the respect for healthcare workers, whether it's sanitation, whether it's policemen, whether it's firemen, whether it's nurses, whether it's technicians, has to be there. There's no question. I think hats off to this. This has been exactly like what we've seen from the army. This is the army. This is the frontline warriors. But the other aspect is...
What is the costing part of it? Because people are complaining that overcharging now, government is to intervene all the time. Because doctors are doing very well, because 500 doctors are sacrificed, life, which is a very... We should be proud of them that they have done.
That's right.
But what about doctors or hospitals overcharging expensive things? That brings a bad name to the...
Actually, no, I don't know about overcharging. There were some reports, if you recall, of overcharging very initially on at the time when COVID started. But in a way, the government of every state took notice of these issues, and they were, by the way, they were far apart. They were small and far apart. But actually, it was appropriate for the governments to come up with at least some form of a capping. And now every state has a capping, and that's been there for the 3 months since the mandate was on. So there's no overcharging at all from anybody. Can't overcharge because it's all capped. Every price is capped. Every charges are capped. Each state has created a own system of capping prices in discussion. Some states in discussion with the healthcare providers, others without discussion with the healthcare providers, but capping has been now come in every state. So COVID has become a state treatment, should we say. And even the best of the places. The only things which don't get charged for are the experimental drugs, but they are charged at whatever it costs. So I think that part is clearly not an issue anymore. We were coming to the revamping of the whole system. See, the first thing is revamping of the education. We can't live in archaic medical education. And this medical education, if you're going to change for the future, has to include things like understanding research, understanding innovation, which has never been part of a curriculum, ethics, which has never been part of a teaching in a medical school, communication. How do you actually have empathy with the patient? Never been part of any curriculum. I think time has come for all that to be an integral part of understanding right from the point where a doctor enters into a medical school. There are other aspects of practical education, which actually start from, as you get into the hospital, you start meeting patients and you start treating patients, something which was left to much later on in the medical curriculum. So the change in medical curriculum has happened. By the way, that is going to be instituted very soon, and it's going to become a regular part of the curriculum because teachers have been started what they call being educated on the changes in curriculum which have happened. The second
medical commission has been
yes, but the change, you're so right. The National Medical Commission is instituting that, but these changes were already proposed and cleared and put down for its execution now. So it's actually been worked upon over the last 5 to 6 years. That curriculum change through numerous discussion had been instituted. The National Medical Commission is now going to institute that. The second aspect of it is, it's not the number of doctors we keep talking about, and we keep saying, but WHO figures said, we should have 1 in 1,000, and we actually only have 0.7 per 1,000. But look at the unequitable distribution. We need to address that first. We're talking about 70% of the people living in the rural areas, and yet 70% of the top doctors working in the urban areas. We're talking about 70% of the patients being treated in the government hospitals. We're talking about 70% of the doctors working in the private sector. We actually have allowed this to happen over a long period of time because we neglected healthcare and we did not plan and strategize what a healthcare of India would look like. Even when I was in medical college, 40 years ago, I was being taught that one Australia gets added onto India every year. Now, if you have a whole Australia getting added, shouldn't we actually have thought, how do we actually take care of healthcare of such a big population getting added on? So we actually, therefore, did too little, too late, till a situation became a default strategy where anybody who became a doctor provided his services in whichever manner, be it the government he liked, be it opening up a clinic he liked, be it opening up a nursing home he liked, or finally transforming it into corporatized healthcare providers, whichever manner they liked. A default strategy without any direction of multiple verticals working as if it's a train line with doing the same purpose, but never meeting together and never actually at any stage being brought together to say, let us think together as to what we mean to the nation. After all, healthcare is the most important thing a nation should focus on. Why can't we sit around and decide as to what India's healthcare should be like? And unfortunately, years and years passed by till recent times where a focus started happening on provision of healthcare to people.
Dr. What final thing, which is that Dr. Ashok Seth said it will 25 to 30 crore vaccine will be available by July. I don't understand the statement. By that time, 25 crore people would have been vaccinated. That is what he meant. And what do you think? What could be the protocol of distributing this vaccine? When will they be available? Because you must be part of the to this information. What is happening in that?
What is happening in this is that, firstly, of course, we don't know which vaccine, but there's going to be the logistics also work on the type of vaccine, whether it's single dose or 2 doses of vaccine, because that's a huge logistic. Everybody's got to be vaccinated twice. The second huge logistic is it going to be kept cold or can it be kept at a normal temperature? Because that's another huge logistic of getting it to the people. Producing any vaccine in the country and having millions of doses is probably not the issue, because India is the biggest vaccine manufacturer of the world. And every vaccine would actually give their ability to be able to be made locally in the country. So the logistics are going to relate to not the number of doses, but it to go downstream on these two logistics. And the third logistic is how many months of immunity does it offer? Because again, that means revaccinating the whole population. Till we come to know these three, the logistics is going to be huge, but it's going to start from it's going to start from healthcare workers, frontline healthcare workers, the one in immediate contact, the one with a distant contact, which is all healthcare workers, and all susceptible people, which is going to be above the age of 60 or 65, or those with immune suppression, etc. And then it's going to go downstream. But it's not that the whole 100% of the country needs to be vaccinated. You get to 70% vaccination, you probably actually start this organism disappearing from the country itself. And we got to actually therefore imagine that logistics is going to be totally based on the type of vaccine and which vaccine and the immunity it offers. But it'll still take a year and a half to 2 years to complete any strategic task for a country of this size. And that's what
it's going to start.
We can't say when it starts, because it's only going to be when a robust vaccine does become available. And approximately, if you're going to talk about when do we think it'll become available?
Yeah.
We think that it'll become available in the first quarter or end of first quarter of 2021. So by the mid of 2021, we should be, because even the earliest vaccine, if it clears its trials and it's analyzed and accepted, is going to be by the December of this year, which means the logistics of subsequent approvals, etc., is another 3 months. And then comes the manufacturing and distribution and everything. So we really, I don't see a vaccine approaching us in a manner that we can actually have it by the second quarter of next year.
Doctor,
it doesn't mean the vaccine won't be available, but I'm actually getting vaccinated.
Right. Doctor, there's always been a bit of a conflict, correct me if I'm wrong, between epidemiologists and cardiologists. Each one thinks they know the healthcare system better. Has this finally brought the two together in India? Because we've still seen a predominance of cardiologists in the policy making.
So we shouldn't think of it as cardiologists. We should just think of it as intelligent physicians. The intelligent physicians, and I say, because it's while it's a respiratory system disorder, it goes through the mouth and affects the lungs. Therefore, much of it can actually come to be an intelligent physician's disorder. But the epidemiologists are the ones who can actually, through their understanding, not the treatment options, but actually the preventive aspects of it in the community. That's why it's a think tank. And that's why I don't think, because it's a new virus, no one can claim to be an expert at it. Even the virologists, the epidemiologists, the infectious disease specialists, and the physicians, the respiratory physicians, the critical care, because a lot of patients who are serious are the critical care specialist domain, anesthesiologist domain. I think all of them have got together on multiple occasions at various time points to define how to tackle this COVID-19 disease and what do we actually project for the future and in times to come in terms of both management options and cure options. And by the way, I say cure options, there is still no defined cure for this virus. There's only one drug which has been shown to save lives, and that's dexamethasone, the steroids itself, which we use so commonly in every disorder. That's the only drug till now which has been shown to save life in COVID.
Doctor, just a quick question, which is not exactly related to India, but we've seen Boris Johnson get it. We've seen now President Trump getting COVID. Will that finally convince politicians that they ought to invest in science, that they ought to invest in medical care globally?
A very, very good question. I hope it does. That's what we can say. It actually brings to you the reality of see, a number of things happen when a person gets COVID or gets close to COVID as much as this, where either gets infected or a relative close to. But, you know, when you say, okay, will it make anybody think? But everybody practically has had heart attacks, or a near and dear one. I mean, I won't say everybody's had a heart attack, but someone close to us, whether it's me, whether it's you, someone close to us has already had a problem. And we know of many people who have had problems. Of the policy makers and the regulators, many of them have had heart problems. And does it change anything? I think it has to be a will and a vision, understanding that healthcare as a whole, and you don't need COVID to tell you that. It exists. A cancer occurs in so many people who yourself and around you. Heart attacks continue to occur. Hypertension and strokes continue to occur. All infections is the last. It's so much of it happening that people are dying from the biggest killer, the second biggest killer, and the third biggest killer are all non-communicable disorders.
Yeah.
And they kill your dear and dear ones. And if realization was to come, it comes from healthcare, and saying healthcare of a country is perhaps the most important aspect to be looked at. If a country is healthy, the nation grows. If the country nation grows, it grows with positivity. And if health of the nation has to be looked at very meticulously. Unfortunately, we've left everything a bit too late. It actually therefore needs something which needs correction, would actually take a few years. It cannot be changed in a couple of years. No policies and no regulations will transform it in any manner, apart from actually believing that over 10 years' time, if there's a will, there's a way, we will see a new healthcare for this country, because the will and the vision has to be there. I certainly believe to tell you frankly, I certainly believe that the Ayushman Bharat has been a wonderful thing for at least providing that there is a reality which can be moved forwards. There's a reality on a path which we can take forwards. We still have to define that path year by year. We still have to sit down with every stakeholder to define it in a much better manner. But at least this all-round reality exists. It has good leadership. And I believe that that can transform the path, not in 2-3 years. I think that's a small time frame. And if it's going to be 2-3 years to define it, then it could be a shortcut. But if somebody tells me that can this path be defined over a 7 to 10 year period to transform the healthcare of this country, yes, it can be defined, because till now, we've only lived in default strategies of healthcare provision in this country. At least we have a firmer path and a vision ahead for defining healthcare delivery.
Right. Mr. Chawla, last question.
I want to ask you, Doctor, tell me one thing. Only one way of not getting COVID is stay at home. Out of your room. Is there another possibility?
No.
But there's so much of scare that I'll get out of my room and door.
You're so right. I think what I want to emphasize in this last bit.
I'm sitting here in my office. I'm feeling when I go back home whether I would have a COVID.
No. I think the scare should not be there. The caution should be there. And yes, as we emphasize very clearly, masking and physical distancing is utmost important.
There is a mask I'm carrying every time with
absolutely.
me. I've got a sanitizer with me.
100%. Now, this is the new normal, you call it. But I will actually tell you one thing. I can never say that this is the new normal. It has to be the new abnormal. Okay. Now, we have to do this at this stage, because this is the only way public can participate in prevention of COVID disease from spreading. The virus wants to infect, and the only way it survives is by infecting one, then to the other, then to the other. And if we stop the spread of the virus, it is up to the public to be able to do it and at least control it to an extent. Otherwise, we will have such widespread disease that somehow we actually could see a lot of deaths. Now, I will let's just give you this
I'm
moment.
just raising a question. You can answer all that. I'm worried about my driver. I'm worried about the person who cleaned my house.
Yes,
the cook is coming into my kitchen. So
do make sure that they are masked and they stay distant. Yes, I also have the same, and I would also let you know that I turned up positivity in one of the people who were working in my home. except that he also wore mask and we also wore mask and none of us got affected.
In
So I
the
don't
house.
think you live
In
in
the house
fear.
we have
Yeah,
to
in
wear-
the house, absolutely. So you have to live with precautions, and the precautions will save you. Unfortunately, people wear those masks under the nose, not
Yeah.
even on the mouth. In fact, when they talk, they talk with the mask down. That's the time when actually the virus spreads the most, when you talk with each other, and that's when the mask is down. People still amongst in their offices would like to sit and have cup of teas and coffees with their friends in the canteen, which is the worst time with the mask down. It doesn't stop you from actually meeting people. It just takes you from precaution. So I don't want you to live in fear. I actually only say this.
You're suggesting in my own home, I have to have mask all the time.
No, you don't live in fear. Yes, you do have to have the mask on. The normal may be a year later, the normal may be 2 years later. But what was the normal? The normal was when you and I could sit together and have a good time. When we could invite our friends together, where 15 of us could have a good time. The normal was when you and I with our families went out to movies. That was normal. When the normals are when you can take your grandchildren to a museum and show them what, the various aspects. You can take them in a park. You can take your grandchildren and children for a holiday and say, let's go and have fun. And we're going to go to the busiest place and have a fail of a time. That is what normal is. And that normal is when two of us, your spouses, can go away somewhere else and have a good time. But that will still come. We cannot actually live this abnormal all the time. But to get to that normal, I must say that we have to live this abnormality. And this abnormality is only there for a year or 2 years. Once we have the vaccine, once we have more robust data on the treatment options and trials are going on. And by the way, humanity has always overcome every aspect in the past, every disease process in the past. It's overcome it hugely. And humanity and science together will overcome it. But what it's made us do is also look forward to the normality, which we didn't value in the past. We never valued those normalities in the past. Now it makes us realize what the normality is. And also it's brought us more closer to spirituality. It's brought us more closer to the Lord above, saying we can actually be picked out from a small submicroscopic non-living particle which stopped the world in its tracks and created a havoc.
Thank you.
We will win over it, but at this time, we have to have a realization that we have to do all this to win over it.
Thank you so much, Doctor. I think that was a really positive and heartwarming message in these very dark times. Thank you, Dr. Seth. Thank you, Mr. Chawla.
Thank you. It was a pleasure to be with you all.